Good evening, everybody, and welcome to tonight's EEL webinar. Please excuse the delay. We're still facing some technical issues, so our speaker will be joining us a little bit later. We're happy to start the EEL webinars again after the summer pause, the summer break. Tonight's topic is going to be about the challenges of the diagnostic and the therapy of diaphragmatic endometriosis. Before starting, we would like to thank our sponsor, Gedon Richter, and for that we'll be playing, as always, a short video.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission.
Okay, so it is our pleasure to introduce our tonight's moderator, Professor Taner Usta from Turkey, Istanbul. He graduated medical school at the University of Istanbul in Turkey. Also in Istanbul, he performed his residency training. After that, he joined the education program about pelvic neuroanatomy and chronic pelvic pain in St. Joseph Hospital in Arizona with the St. Louis University in Missouri, USA. He completed the education program from the International Society of Neuropelviology. And he also, where he passed the exam, and then after that, he joined an intensive hands-on course about neuropelviology in Aarhus in Denmark. His interests are in laparoscopy, robotic surgery, endometriosis, and pelvic pain. Now he's working at Acıbadem Hospital in Istanbul since March 27. He was the General Secretary of the European Endometriosis League, and he's the President of the Turkish Endometriosis and Adenomyosis Society. He was also a board member of the European Endometriosis League from 2019, as well as from the European Society of Gynecological Endoscopy. Taner, we are happy to have you here, and hopefully we can soon start the presentation as soon as our speaker is going to be with us.
Okay, thank you, Alin. Do you hear me?
Yes, everything is fine.
I start with some words, and so I hope that Roberto will join us. 10 minutes ago, we get in contact with him, but I guess that he dropped, and we are waiting him. Good evening to all Endo friends and Endo family. We came together in Bordeaux for last EEL Congress in June this summer, and so it was so successful. I congratulate Horace Roman and all his team, and the previous EEL president Engin Oral, and the previous EEL board members. There was, you know, that there was an election for new EEL board during the last Congress. First, I would like to congratulate new president Harold Krantel and new EEL board members. I hope that they will be more successful than before. They will carry the society even more. And then, thanks again to Harold for this kind invitation. Today, Roberto Clarizia from Italy will talk about endometriosis of diagnosis and treatments, and I will moderate the topic. We know that most common sites of outside pelvis are the diaphragm and thoracic cavity. However, diagnosis takes a long time, and treatment is not easy and very challenging all of us. Currently, there are no comparative studies to provide recommending diagnostic methods, treatment options, and outcome endometriosis involving extrapelvic sites. When we look at the previous ESHA guideline, which was published 2014, there is only one paragraph about extrapelvic endometriosis and some small words about diaphragm endometriosis. There is no specific algorithm or treatment recommendation was there. And when we look at the latest ESHA guideline, we see the title of thoracic endometriosis syndrome, and you can only find a one-page information, and there is a need much more information for treatments and the diagnosis of thoracic endometriosis. And now today, Roberto will talk about diaphragm endometriosis, diagnosis and treatments. I will a little bit talk about him. He is vice president and founder of International School of Surgical Anatomy. We know that Marcello Ceccaroni is the president of school. He had medicine degree and OBGYN specialization in Federico II University of Naples and PhD in reproductive medicine in the same institution. Since 2007, he is focusing on surgical treatments of endometriosis. I hope to join us. Could you give me some information? Roberto, are you here? We are waiting to Roberto.
He is not here. We're still waiting for him.
Okay.
I think Governor is still.
Tana, thank you so much for your.
Okay.
Tana, thank you for your kind words in the introduction. You published some months ago a review on diaphragmatic endometriosis.
Yeah.
And there's, despite of the fact that we did not even start the lecture, there's one question from the chat, and maybe we can discuss it. Before we hear the lecture. The question is, and it's regarding the diagnosis of this special localization of the disease, if ultrasound and elastography play a role in the diagnosis of diaphragmatic endometriosis. Maybe we can discuss this a bit meanwhile we are waiting for Roberto.
Roberto is in the house.
Normally
he's just joined us.
Okay, we are waiting the Roberto. And I guess that we can ask and discuss a few minutes later this question. Thank you so much, Harold. If you ask me which one is difficult, diagnosis or treatments, both of them, I guess, very difficult when we talk about in terms of diaphragm endometriosis. Roberto, do you hear us? Could you open your microphone, please?
Okay, sorry, I had to change my computer. In the time presentation, the Mac was down on battery, but I think not the battery, the complete system was shut down. Okay, but I'm okay now. I can share on the screen if you want. Did you start with the presentation?
Yes, we are ready to hear you, Roberto. Okay.
And sorry for the delay. I will go directly with the keynote. Okay. Okay. You can see. Okay. Can you see me now?
Yes.
Okay.
Could you share the screen, please? We only see your picture, but we cannot see your presentation. Could you share?
Okay. Share the screen. Yeah. Okay. Yes, I need the system preferences. It's a mess, the Mac today. Okay, let's share the
You need to
screen.
give the permission.
Yeah. Okay, I think now we're okay. Okay, now you should see the screen.
Not yet. We are waiting. Yes.
Okay,
Cool.
finally. Okay.
Yes.
Okay, so can you hear me well?
Yes, yeah? Very well. The picture is perfect,
okay.
And your sound is perfect.
Okay, thank you first of all for the opportunity of being here, and thank you to my master Marcello Ceccaroni, which cannot be here, but is ready to hear us and has given me tips. So what about thoracic endometriosis and diaphragmatic endometriosis? We know that the Sampson theory may explain most of the lesions on the diaphragm because retrograde menstruation leave the lesions. The laterality of this lesion is very important. Is something we know from Sampson in 1927. The first article was very interesting because it described the laterality on the right side because the liver stopped with the ligaments, the flux of menstruation, and so most of the lesions effectively are on the right side of the diaphragm. So most of the peritoneal lesions on the diaphragm may be explained with this theory, but Sampson was not only the father of this theory, but also of hematogenic spread, which was made by Alban in 1924, but also Sampson hypothesized this kind of theory for other lesions. So Sampson was not believing only that theory, was believing that some lesions may be explained that theory, but also the hematogenic spread may explain, for example, the isolated pleural and isolated pneumonic lesions, pulmonary lesions with no correspondence on the diaphragm may be explained with the hematogenic spread. And also the metaplasia is a theory which is taking much foot in the last years because the metaplasia may explain the localization on the, for example, upper diaphragm and on the upper thorax, and that is a theory that is more about neonatal endometriosis because the Brosens studies in the last years explained that in the first neonatal period estrogen reactivation may explain the activation of the metaplasia remnants. And last year for this kind of extrapelvic endometriosis is the PGA theory, you know, about prostaglandins, which especially in the thorax lesions may be activating those lesions with the bubble theory. So it's a very modern theory, but especially for the thoracic endometriosis may be one of the most I believe, theories. You know that pathogenesis of endometriosis may explain the laterality, as I said, that the right side, this is a Vercellini very interesting study, right side of endometriosis is explained by the liver, which is stopping with the falciform ligaments most of the flux, and so the diaphragm I believe is a luck for us, is most on the right side. Peritoneal, and so this is explaining one of the studies we published in a very large series of patients, about 1,500 patients. This is the we see now in a year, and you see that the percentage of diaphragmatic lesion is not so low, 0.2% on the all endometriosis population, which in Italy may be about 20% of the fertile. And so these are only the patients that went in, and so it's a very, I believe, high percentage. And we know that endometriosis has a long delay in diagnosis, and this may be explained by the asymptomatic patients, which are in the diaphragm endometriosis, a large series of patients. So many patients have not symptoms till the disease is exploding in the thorax. And so we can explain why the lesions are so big in the first diagnosis. And this is an interesting study which started the theory of the bulla that may be explained by the activation of prostaglandins on these lesions, which are maybe the remnants of acylomatic metaplasia, but maybe a migration with the retrograde menstruation, which in a particular period of the menstrual cycle activate every and the symptoms activation. And what we can know about where the lesions are before going in surgery. We know that the localization of lesions maybe in the thorax is about MRI, because endometriosis signal is characteristically recognized in MRI. But if you look for the pulmonary lesions, so lung lesions, maybe CT scan is a more complete exam, but CT scan may say you where the lesion is, but not if it's an endometriosis lesion not. So maybe a good exam also for exclusion of neoplastic lesions, I believe. And so we can always do the CT scan and also the MRI, unfortunately for the woman. Bronchoscopy is not so accurate exam, because maybe bronchoscopy may recognize only advanced lesions where the disease is much more aggressive. And so we can leave bronchoscopy in patients with symptoms which are very, very strong. But if you look at this study, it's very interesting because the laterality, as I said, shows that the right side is prevalent in all the women. And if you consider that the percentage is about 10% of all the population in deep endometriosis patients, we see that right side lesions are about 80%. And this is the famous Vercellini study explaining the menstrual flux block on the liver. And this is an interesting surgical anatomy scheme in which you can see that is a muscle, but is a muscle which is not so thick. Central tendon, the diaphragm may reach only 1 millimeter. This is an advice for the surgeon going in the diaphragmatic lesions, because you have to manage to do surgery. So easy, because it's a borderline surgery with the general surgery, thoracic surgery, and so it's a delicate area. If you consider that the caval vein is just right here, and the subhepatic veins, you know what harm may cause if you are not so accurate with your surgical procedure. So this is to explain that the vascular risks in a diaphragmatic surgery for sure are not so easy to manage, and also neurological consequences may be very long term, because the phrenic course of the nerve is very close to the diaphragmatic lesions sometimes, and so you have to know very well the abdominal anatomy and also the thoracic anatomy sometimes. This is a multidisciplinary study which you can do before surgery, and you have to manage these lesions many times with a multidisciplinary team. So just a second, I believe you are not hearing. Okay, yes, this is, I believe the connection is blocking the cursor slides because, okay, I can see the slides going on. Can you see the slides going on now?
Yes, yes, Roberto.
Seeing something blocked, okay.
Your voice is a little bit loose.
Yes, and I think I'm okay. And just for the second, because now, okay, I've reactivated the Mac on which I got the best slides. So if you want, there was a first part of presentation I would like to do with these slides, but if I can do with the original Mac, maybe is better for you because there are better movies, and so I can do in this first presentation the anatomical part, and then restart with the clinical part, which in the original computer was well, if you are okay with it. Okay, so just for the audience, because this is the anatomical part in which you can see the phrenic nerve course, and so the attention which must be paid to the surgical maneuvers which may be done, and you see that the pericardium is not so far, and we will see some movies in which the surgeon may manage also the pleural and pericardial region, and so this is a very, very borderline region, and also the phrenic nerve may be damaged after this kind of surgery, and so permanent damages may occur to the woman. This is just a slide to show you that the case series are not so large, and so what about 8 patients, 15 patients, 24 patients, which was the Nejat original study. This is just to show you that diaphragmatic is a very particular disease in which not so many surgeons are expert, and till 2010 just the largest series was 15 in red wine and 24 in Nejat studies, and then we started with Dr. Ceccaroni to do diaphragmatic surgery by laparoscopy, and then also for ovarian cancer, for endometriosis, and now I believe also in the Magriña study you can find about 100 patients by robotic, by laparoscopy. So this is a pioneeristic field of study in which the first experiences were on the about 100 patients, in which all the candidated patients to laparoscopy were studying the diaphragmatic lesions. So the most important thing is when you start laparoscopy, always look to the diaphragm, and then I can show you in the end of the presentation a diagnostic algorithm in which you can see that if you have an incidental lesion which you cannot show in the imaging exams, you have to manage in one manner because the thoracic surgeon maybe is not there. But if you in the preoperative workup have some tip more, and if you have some diagnostic exam that may give you some advice of diaphragmatic lesions, maybe you are more ready to manage, and the informed consent is ready for that woman. So the most important thing I can show you in this slide is the previous surgery for endometriosis that we manage in our center. About 30% of patients have just no intervention before, but 70% of patients have 2 or more interventions before our intervention. So this is to show you that the surgical procedure is more difficult also on the diaphragm, because the liver lesions are, especially on that area, very, very harmful, and is a criteria to stop and call the thoracic surgeon. And the symptoms you can see that are very low in percentage, because if you consider that this kind of women are surgically treated, so deep endometriosis is present in these women, you see that diaphragmatic symptoms is very, very low. So you have to be very acquainted with the diaphragmatic symptoms, but also with no symptoms. So if you suspect a deep endometriosis on the bowel and on the ureter, for example, so a multi-compartmental endometriosis, you have to just have an informed consent also for diaphragmatic lesions, and you have to be ready to treat all the lesions on the diaphragm and on all the other viscera that may be involved. Okay, so this is a basic tip of laparoscopy in which can be useful to treat diaphragmatic lesions. You see that the classic laparoscopic access has umbilical access, and then the median trocar and the 2 axillary trocar. But if you have to treat diaphragmatic lesions, we usually have a 30 degrees camera, and also an upper access may be useful. So this is the basic laparoscopic in which you treat diaphragmatic lesions in the context of a deep disease. And you see that, as I said, when diaphragmatic lesions come to your observation, maybe a very deep endometriosis is present in that woman. Okay. So the upper abdominal phase, as I said, needs a steep reverse Trendelenburg position. So if you start with Trendelenburg position because it is useful for the pelvic phase, then you have to reverse the woman just to access the liver and to maneuver the liver, to free the liver, and to have a good access to the diaphragmatic lesions, because you have to explore all the liver surfaces and all the diaphragmatic surfaces. So the Trendelenburg position is not useful to you because the bowel will come down. And then in the steep reverse Trendelenburg position, you can manage the diaphragmatic area, and a 30-degree camera may be most useful to you. So these are the classical trocars, but sometimes you can add an upper trocar, which is usually the position of the general surgeon access, okay? But these give you an upper access, and the 30-degree camera may give you a better angle to manage the diaphragm and the liver angles, which may be, especially if you got adhesions, very unsuccessful, okay? And so you see that multiple diaphragmatic lesions are quite always present. So it's very uncommon to find just one diaphragmatic lesion. So if you see one diaphragmatic lesion, I believe that you have to explore and to mobilize the liver. So you have to manage the liver as a general surgeon make to reverse the liver and to access the diaphragm in all surfaces of the diaphragm, because you see also hepatic involvement sometimes is present, pleural involvement is present. So you cannot stop just on one lesion. You have to explore all the diaphragm, and if you have a formed consent for radical surgery, to perform a radical surgery also on the diaphragm. And it is a classification that we started to adopt in the context of endometriosis and the diaphragm, but also in the peritoneal endometriosis, because how we can distinguish, because deep endometriosis and superficial endometriosis, we know that deep endometriosis is more than 5 millimeters, but on the diaphragm we have a better thickness of 5 millimeters. So you see that when the endometriosis is present, is just above the diaphragm, just in the thorax. So we call foci, which are less than 1 millimeter, nodules between 1 and 5 millimeters, and plaques above 5 millimeters. And this I can show you better in the last slide, in which algorithm, diagnostic and therapeutic algorithm we created based on this kind of classification. So if you can give me just 1 second, I switch between the slides, because I think that the last slides are better, and much more movies are on the Mac I wanted to use in the beginning. Just is ready. I can switch in 1 minute if you can. Or you prefer to finish the presentation? And
yes,
then,
Roberto, I guess that finish the presentation is
okay, because okay, so I can show you the
and
the algorithm.
in that time we can take the questions, and so we can save the time.
I can show you the moves. Okay, it's fine. Okay, can you see this movie? Yeah, yes, this is
yes,
very common, I believe, diaphragmatic lesion we can expect in one patient with bowel surgery. This was a patient treated by Dr. Ceccaroni for bowel resection, and you see that the diaphragmatic lesions were the one we call plaques, because more than 5 millimeters, and the muscle was completely involved with the full thickness muscle involvement. You see that the diaphragm was completely resected, in this case stripped, but also resected, and so the muscle was opened and sutured, and you see how difficult is to come over those angles with a simple suture, because you have to manage a very uncomfortable leva system. It's not like in the pelvis, and in the end you have to be sure that the CO2, the oxide carbon, is not going in the thorax, and usually we can do it by the communication with the anesthesiologist, and you can also pump some air in the thorax if this opportunities that a pneumothorax is occurring. And this was the series we presented in 2013, in which diaphragmatic retraction and suture were about 20% of cases, and one just intraoperative pneumothorax was present. So a chest tube is not common in our series, because if you are able to recognize just in the time of intervention a pneumothorax, you can manage with the anesthesiologist just pumping some air in the thorax. And you see that some cases are managed also by laparotomy, because if you have just a case like this one, which was, I believe, a unique case in which also pleural and pericardial surfaces were involved, you have to manage with a mini laparotomy. But this was a patient undergoing a disc resection for bowel, and then the diaphragmatic phase, which was the last one you usually have to manage, was by the general surgeon and thoracic surgeon managed with a mini laparotomy from the upper abdomen umbilical lesion region to the 12th cost. And you see that the initial glimpse of that woman was like a superficial diaphragmatic lesion, but if you then accurately mobilize the liver, you see some adhesion was present. You have to manage then something like this, in which the pericardial and pleural folds were completely involved, and a full thickness diaphragmatic involvement was present for about 10 centimeters at the pathology specimen. And interestingly, the pathology specimen was demonstrating a cyst system in the diaphragm. So sometimes that are not nodules, but real cysts, and this may be explained by the metaplastic and retrograde menstruation theory, because you know that sometimes rectovaginal nodules are maybe metaplastic different etiology. And you see that then the reconstruction of the folds of the pleura was made by a thoracic surgeon. And the worry in this intervention was about infection of the pleura, because this resection was made on the sigmoid, and so if a sepsis could occur, this was not a good expectation for the woman. But fortunately, no sepsis, no postoperative complication occurred, because a protective suture was very precise. And you see the size inside the diaphragmatic muscle was completely substituted by cysts. So the diaphragmatic muscle wasn't present here. And this may explain why in some cases you have a hole in the diaphragm. So a woman may be diagnosed with diaphragmatic endometriosis just because a completely full thickness hole is present also in laparoscopy, but this is compensated by the woman, and so many times the symptoms can occur, or sometimes a spontaneous pneumothorax may occur. This is the most, I believe, difficult case we managed, but complexly we managed about 100 cases of diaphragmatic lesions, including the foci every year, and the complications related to the diaphragmatic phases are not so high, because this is in the context of a bowel surgery, in which the most harmful phase is the bowel phase of the intervention. So in conclusion, we believe that laparoscopy for diaphragmatic lesions is very safe and feasible, is effective if you are radical, because if you only go and coagulate the foci and the plaques is not good, because it's the same of coagulating a rectovaginal nodule in the surface. So if you know that that is not a foci but is a plaque, you have to remove and to be radical with a retroperitoneal technique. You have so short operating times and not so high blood loss, but the woman has to be informed about this perspective, because you know that asymptomatic women are the most frequent occasion, and so you have to say that your woman maybe has diaphragmatic lesions we cannot see, and is a good thing to be ready also with a thoracic or general surgeon in your team to face those situations if you have an incidental finding of diaphragmatic lesions. So experienced surgeon about the gynecological side is needed, because you know that if you want to be radical, as in ovarian cancer, you have to manage also the sobramesocolic part of the abdomen, and so diaphragmatic endometriosis means to manage sobramesocolic phases and to be radical and to be a good surgeon in all the abdomen. So if you want to then stop and do some question time about the guidelines, we can show some updated slide. Good thing is coming down in the last years, okay, because I think we are quite a delay.
Roberto, we are ready. If you're ready, you can connect the computer.
Yeah,
and
will reach just in 1 second.
Okay. We have a lot of questions, and I will ask them. And the discussion is very valuable for us, I guess.
Okay. So
we have at least 15 minutes.
Oh, okay. It's a good time. So I'm...
During the connection, can I ask you the questions from the participants?
Yeah, I can hear you.
Roberto, there is one question from Dr. Shihah. I hope that my pronunciation is good. I'm not sure. Any role of elastography to diagnose diaphragm endometriosis? Do you have any experience about elastography for diaphragm endometriosis? You mentioned about CT and MRI.
Yeah.
But there's a very interesting questions about the diagnosis.
Yes.
Elastography.
Yeah. I can show you something about PET scan, because we are now trying to diagnose the diaphragmatic endometriosis with the marked estrogens. And so this is a very nice perspective, because the results are very nice. It's a quite expensive technique respect of MRI or CT scan, but I believe in a so unique condition may be a good perspective, and so I think the answer is absolutely yes, is a good perspective.
You mentioned about PET, not elastography, is that right?
So
elastography.
Elastography, okay, yeah. The elastography is a good item we adopted also in the first decades, and was very accurate item, but the problem was that it was so dependent from the radiologist, and it was a man-dependent, human-dependent technique. I don't know in your experience how it works and how it was your feedback about this, but in our experience it was very dependent on the operator. So we try to use, if we can, all techniques that are dependent on the gynecologists in the last years.
Okay.
I don't
Next
know
question.
if you personally do this exam, or you leave it. Okay.
Could you? Yeah. There was echo. And the next question is: do you hear us, Roberto?
Here with the other one has which.
Okay.
So,
yes.
Okay.
Yes. From Israel, Ahmed Namazo asked us, what's your management in incidentally diagnosed diaphragmatic endometriosis during laparoscopy due to the pelvic endometriosis? Do you put another trocar to treat them?
Yes.
Second, or you refer the woman to imaging to see the extension of disease.
Can you see the slide now?
And there is no shoulder pain.
Okay.
He adds additional information of the patients. You see the diaphragmatic lesions, but the patient doesn't suffering shoulder pain, and there's no complaints. Do you touch or do you don't touch?
Perfect, understood. Okay, this was about the guideline I would like to show you. This is algorithm we tried to manage in the last years, in which the starting point was the symptomatic or not symptomatic woman. So if you got the diaphragmatic symptoms, you start with a precise series of exams. But if you're not having diaphragmatic symptoms, you start with endometriosis surgery, and as you said, you may have an incidental finding of diaphragmatic nodules. And what you do in these cases, you operate the woman for bowel and for the
Roberto, sorry, could you close the colors information below the screen? It's covering the image, or you can make it full screen. Yeah, it's perfect now.
Okay. Okay, sorry, I believe it was only in my screen. Okay.
No, it's going on.
So if you are going to perform a laparoscopy for a woman with other symptoms and other localization, you go and you are doing your endometriosis surgery, and you have an incidental finding on endometriosis on the diaphragm. So what you do? You are treating by laparoscopy all the lesions, but you find the diaphragmatic lesions. You have to distinguish if are foci, so superficial lesion, you can do a coagulation. If are deep lesions, inside the peritoneum, and if a muscle infiltration is present, you can do a simple stripping. If a massive muscle infiltration is present, a nodulectomy, and if a bigger infiltration is present more than the half of the diaphragm thickness, you have to do a resection and a suture. But afterwards, you have to put the woman in a follow-up with the thoracic surgeon, because the right algorithm should be this one. So if you find that the diaphragmatic lesions before your surgery, you have to manage with a multidisciplinary surgical approach. So sometimes a thoracoscopy is the first thing, and then the laparoscopy is the second thing. So if you have an incidental finding, our belief is that you have to be ready to treat your gynecologic lesions and to be ready with an informed consent signed by the woman. So not afterwards to say the woman, we cannot treat it because the informed consent was not present. So you have to do your part and to finish your radical surgery. And then if the lesion was not known and also thoracic part must be treated, you can demand on a second intervention. And otherwise, if the lesion was present and known since the beginning, you can start with the general surgeon. So this is our algorithm. About the additional trocar, yes, we put an additional trocar on the right side in the upper abdominal subcostal, like the, to 12th cost, about 4 centimeters from the 12th cost. But another occasion is on big midline lesions, which the gynecologist can treat, and diffuse or multifocal lesions, or tendon lesions, or severe liver lesions. In those cases, if you have an incidental finding, you cannot treat by your own, because you need a thoracic surgeon since the beginning. So this is, I believe, is what you can manage about all the lesions.
Thank you so much. It's very beneficial to understand, but I have one question about infiltration of the lesions of the diaphragm. How can you sure that this is more than 50% attached the muscles or below 50% during the surgery before any intervention or imaging technique?
Yes, usually you can touch by laparoscopic feedback. So in this kind of surgery, we believe that laparoscopy is superior to robotic just because if you are a very strong and experienced surgeon, you can recognize by your touch if the lesion is going down. And mainly in this phase, Ceccaroni stressed about the cut of the peritoneum, because if a first approach is not cutting in the lesion, but just cutting the heel peritoneum, so outside the lesion, you can then extraflect and go by retroperitoneal way till you see the lesion, and so you can see if the peritoneum only is involved, you see that this is a superficial lesion. If the muscles start to be involved, you see that less than the alpha means that when you are cutting, you are not transpassing the diaphragm. If you transpass the diaphragm, so is the alpha. So you basically you have to be ready to all the opportunities, and it comes when you are doing this. The important thing, I believe, is to distinguish between the peritoneal and the full thickness lesion. So if you start retroperitoneal, you can do the stripping and not opening the diaphragm, and so only if adhesion occurs. So this is the main distinguish, I believe.
Yeah, the most difficult part is if you face deep infiltrating lesions on the diaphragm. So there is another question from Ahmet Kale. He's asking us for MRI, which sequence is important, T1 or T2, and what is the advantage of contrast agents? Is there any beneficial effect for diagnosis?
Basically, the endometriotic signal is like the endometrial signal with the T1. I'm not a radiologist, but T1 lesions, T1 signal is the basis, and the contrast is not required usually for endometriosis. So our radiologists don't use the contrast in MRI for endometriosis because the signal is not important. But if you are coming next to the lung, the contrast is important to distinguish between the lung, the pleura, and the vascular side of the lung. So the contrast maybe is important only if you suspect lung lesions and not diaphragmatic lesions.
Okay. Is it important to menstruation or outside the menstruation when you're planning to MRI?
Yes, our more expert radiologist, which is Dr. Menni, requires for diaphragm to do the MRI during the menstrual cycle. Because some lesions may be too small, and to recognize them, you need to have a bleeding.
Yeah. Okay. And other questions, I guess that is coming from Alin. Are there any situation when you would place a pleural drainage?
Yeah, usually we, as I said, try not to put pleural drain, because if you can recognize the infiltration of CO2 during intervention, you can drain directly with an aspiration, just also with the laparoscopic insufflator. So only if you have a postoperative pneumothorax, we put the pleural drain.
You mentioned about the phrenic nerves. There was one question about the phrenic nerves, diaphragm nerves. Have you ever faced any nerve problem after the surgery?
Yes, yes, we faced some problem, but was about the patient with the pleural and the pericardial infiltration, and so that was managed with the postoperative service. Big painful syndrome afterwards, and so was treated like a neuritis, but was healed in 1 month. And this was one woman. And about motility of the diaphragm, we know that a stupor of the phrenic nerve always occurs, so these have to be treated in all cases. But very paralyzed diaphragm have never occurred to our experience.
If you suspect the phrenic nerve damage,
Yeah.
Do you apply a specific diagnosis for the diagnosis of phrenic nerve damage?
No, because electromyography is not so precise on the phrenic nerve. No. I don't know if you experience, but it's not can manage with the common exams you do, for example, for the radial and the brachial nerves.
From Ahmet Kare again, most of the diaphragmatic endometriosis lesions at the posterior side of liver, and it is very important. If you look at the anterior side, you cannot say that this lady haven't had diaphragm endometriosis. You have to look at the back side. You have to look the dome of the diaphragm. Do you always cut from ligament to prevent overlook these lesions, or do you have any route not to skip posterior liver lesions?
If you see that the lesions are multifocal, yes, we always cut the falciform ligaments and inspect all the diaphragmatic surfaces. So the answer is yes. If you are treating the multifocal lesions, we always cut the ligaments and mobilize.
Yeah, there's a very good question. Should the laparoscopic excisions of diaphragmatic endometriosis be avoided concomitant to a bowel resections to prevent the increase of the complications, both sides?
No, I said about the woman with the cardiothoracic endometriosis. We did this resection in that woman, and we basically the answer is you cannot do this because the bowel phase is the first and the diaphragmatic is the second. So if you are going to treat bowel lesions, you have to do in the first, because if you treat diaphragmatic lesions in the beginning, the infiltration of the retroperitoneum make you the silk to go on an intervention. So the basis is this. Don't decide to do one or other procedure. Basically, we may or protective ileostomy if you want to prevent complications, but not to leave another intervention to be done in subsequent time. So we believe in the radical surgery. We believe that a second intervention would be more harmful than multi-compartmental intervention.
But on the other side, Roberto, it takes a very long time, a long time surgery. I guess that this question coming for that one. And so if we face two complications, another localization can increase the morbidity and also mortality. So we always discuss this one. If the lady have a lot of lesions, and it's not a surprise for us, we know the percentage of the lesions in the pelvis and also in the diaphragm. We know that, I guess that the participants know that if the lady have a pelvic lesions, they have about 1% diaphragm endometriosis. But if the patients have a diaphragm endometriosis, it is over 50% have a pelvic lesions. So the main problem is, yes, your team is very experienced center and you have a very high volume. And because of that, I guess that you have a lower complications rate. But can we say that all centers have to apply the same lesions?
That you know about the diaphragmatic lesions when you are doing surgery for the other lesions, is not common to find someone going in ER for only diaphragmatic lesions, as you said. So it's not common to say I found diaphragmatic lesions in this woman, so I go to ER only for this one. So the symptomatic part of the lesions are most about pelvis. So yeah, is a good opinion yours, but I believe it's not frequent to have a woman only with diaphragmatic symptoms and then you find also the pelvic part to be treated, and so you separate the two parts. But we do this when the diaphragmatic lesions are needing a thoracic surgeon, for example. We do it 2 times, yes.
There is one technical question. What kind of laparoscopic instruments are you using?
Yes. What you saw in the movie was a bipolar scissor, which is yeah. And usually on the diaphragm, you can very well manage the cut with multifunction, like harmonic or thunderbit. And if you want only to coagulate the superficial lesions, we usually use a CO2 laser limit.
Okay.
Roberto, my technical question was regarding the length of the instruments, because as I saw in your picture, you're placing the camera at the level of the umbilicus, and then you place 3 more chokers, 2 on the sides, 1 in the middle. But the ones on the sides are not at the same level as the umbilicus, are slightly lower.
Yeah, yes, this is our kind of laparoscopy making, because it was for the pelvic part, we need the 2 ancillary trocars just lower than the central one, because if you want to reach the pelvic floor, you have to put this way, and so you can put another trocar cranial to that one on the right side to reach that.
And just with the extra one placed in the upper abdomen on the right side, do you manage to access all the lesions? Because
yeah, you can. For example, one good tip is to change the camera trocar, so you can put the camera in the thoracoblique trocar, changing to a 10 millimeters, and then put the 5 millimeters adapter in the umbilical trocar. So you have 2 trocars on the upper side. You understand what?
I see, so because for the endometriosis, I'm placing always the trocars at the level of the umbilicus, one on the right, one on the left side. And even in this situation, I'm having difficulties to reach all the lesions, especially the ones that Ahmed was talking about on the posterior side of the liver. So usually I'm placing another one on the midline in the upper part of the abdomen to have access to the whole diaphragm.
No, but a good tip is to put one more here, and this one is becoming an operative trocar. Put the camera here. Okay.
Upper right hypochondrium is a very good place to use a trocar placement.
So you change the number 2 trocar to a 10 millimeters. You put the camera here. Or you camera here too.
There's a lot of questions, but we a little over our time. Alin, do we finish or going on to questions?
I think 10 more minutes. I think we can do it if everybody agrees.
Okay. How long do patient? Yeah. Okay. Roberto, you mentioned about, but it's a very important question. You showed us your procedures. How long do patients stay in hospital? You mentioned about 7 days. It is routinely planning 7 days staying in the hospital, or shorter or longer in some situation?
The hospital stay depends on the bowel phase, because if you got a bowel resection, can stay 5 days. If you have got no bowel resection, only for the thoracic part, if you didn't put the drain, also 3 days is good. So as you said, the bowel phase is the more incident on complications and also on hospital stay.
And the other question is, do you recommend, do you use any drug after the surgery? Do you have any specific treatments protocol after the surgery?
Yes, is to avoid the opioids, to not to stop respiration. So the anti-pain, the painkillers is based on the paracetamol 3 times a day in fixed therapy, and after 7 days, if neuritis is starting to occur, prednisone 25 milligrams per day, and pregabalin 25 plus 25 therapies are pain neuritis therapy for
Roberto, do you hear us?
Sorry, and physiotherapy, obviously.
Okay. So I guess that this question is for prevention of recurrence.
Yes.
Do you generate, or do you use oral contraceptive pills or progesterone?
Yes, we recently published a study, which was the first RCT study in our center about postoperative therapy, and the GnRH therapy is equivalent to the analgesic. So usually, if a woman is not searching suggest postoperative amenorrhea therapy, and we believe that GnRH or the analgesic is equivalent.
Roberto, I want to ask about medical treatments. If you diagnose multiple lesions on the diaphragm, do you offer medical treatments, or do you always recommend surgery?
I believe that to recognize multiple lesions is very hard before surgery, because maybe the radiologist talks about a single plaque, but I personally, and I believe our colleagues suggest a GnRH therapy. Be sure of diagnosis before going to surgery also, because if you are not sure about your diagnosis and the woman is the woman is 40, maybe you can propose only medical therapy, and to go till menopause with the GnRH if the woman is a good thing.
Do you recommend that ladies, if the ladies over 40s or 45, bilateral oophorectomy after the surgery?
Not after the surgery, because I believe many times those women are not reaching that age because they require, or you're proposing hysterectomy before, and so the problem is solved some years before. But if you have a particular woman woman to do radical surgery at the age of 40, because they want to go to do hysterectomy.
There's a very interesting question coming from the participants. What symptoms have you seen, especially left-sided endometriosis, apart from shoulder pain?
Yes, sometimes arm and the forearm pain is very strange, but mimics that gastric cirrhosis, and so yes, like left hypochondrial symptoms. Yes.
Okay, I guess that we completed our time, and so all participants can valuable and discuss their. They think that this is not a very hard test. Roberto, you experience about your center and I guess that they benefit all information. I really thank to EEL for the opportunity of this webinar. And so I thank the Alan and all young team of EEL and Health Grant and thank you for Roberto. Do you add any information or something? Your thoughts?
Thank you for the patience you had with the computer, because I'm very fond of my computer. I a little expert of computers, but always in the time of a webinar, the computer shut down. So thank you, because I wanted to show this algorithm in particular. And so
yeah,
I know that the switch is not a good thing during the presentation. So I thank you for this problem solving. And thank you all for the patience and for the time you spent with us.
Okay.
Thank you,
Don't worry
Tana,
for the computer
Roberto.
problem.
Very good presentation. Thank you so much.
Thank you. Thank you.
Thank you. Bye-bye. Have a good evening.
Bye.
All of you.
Good evening. Bye-bye.
Thank you, dear Tana. Thank you, Roberto. Bye.
Thank you. Thank you, Harold.